Welcome and thank you for joining today's Primary Care Collaboratives webinar on primary care's important role in advancing health equity. My name is Sarah Coombs and I am the Director for Health System Transformation at the National Partnership for Women and Families. The National Partnership is a nonprofit policy advocacy organization based in Washington, D.C., dedicated to promoting policies and creating conditions that improve the lives of women and their families by advancing both economic and health justice. Among our core areas of focus are improving access to affordable, high-quality healthcare, reducing inequities in health outcomes, addressing the persistent maternal health crisis, ensuring meaningful access to reproductive health care, including abortion, and promoting health system transformation efforts that mitigate racism and bias and foster equity for patients and consumers. So for today's topic of discussion is very much aligned with our work and our mission, and I'm excited to learn from the panelists today. Before we get started, I'd like to make a few housekeeping reminders. All lines are automatically muted. We'll take questions from the audience in the last several minutes of the webinar. You can submit your questions at any time in the question box. The webinar is being recorded, and the recording and slides will be available shortly. So for today's panel, we'll be discussing primary care's important role in healthcare equity, supported by a new report called Primary Care, a key lever to advance health equity. This report was co-authored by the Primary Care Collaborative, Morehouse School of Medicine, and the National Center for Primary Care. I'm excited to have expert panelists from different fields of primary care join me today to discuss their take on the report and key recommendations that all of us should advocate for to advance health equity. This webinar is co-hosted by the Primary Care Collaborative and the Primary Care Development Corporation. For those who are less familiar with the PCC is a nonprofit multi-stakeholder organization that unifies and engages diverse stakeholders in healthcare and promotes policies and shares best practices to support the growth of high-performing primary care. Their membership includes more than 60 organizations committed to advancing an effective and efficient health system built on a strong foundation of primary care and the patient-centered medical home. This webinar is also part of the Better Health Now campaign, which launched at the end of March. This is a campaign of the PCC committed to increasing investment in primary care and promoting primary care payment models that ensure all communities have access to care. The link being put in the chat now will take you to ways your organization can sign on to the campaign. First, we'll hear from Ann Greiner, President and CEO of the PCC. Ann will provide us with a brief overview of the report before we dive into the discussion. Then we'll hear from our panelists, Dr. Dominic Mack, who is a family physician by training and currently serves as the director of the Morehouse School of Medicine's National Center for Primary Care, also known as NCPC, the nation's first congressionally sanctioned center to develop programs that strengthen the primary care system for health equity and sustainability. Dominic also practiced for 11 years at Southside Community Health Center in Atlanta, Georgia, where he served as Chief Medical Officer. Louise Cohen is next. She is the Chief Executive Officer of the Primary Care Development Corporation, PCDC, a nonprofit community development financial institution dedicated to building, expanding, and strengthening access to quality primary care through capital investment and practice transformation, as well as policy and advocacy. Prior to PCDC, Louise was Vice President for Public Health Programs at Public Health Solutions in New York City, where she oversaw a variety of programs to improve community health through food access and nutrition, women's reproductive health, tobacco control, and the child development. And finally, Dorothy Simon, Senior Vice President of the Office of Policy Development and Integration at AARP, where she's leading efforts across the organization to address the major issues facing older adults, including health and economic security. Dorothy also previously served as Director of Health and Long-Term Services and Supports at AARP and as a Senior Litigation Attorney for the AARP Foundation. Now I'll turn it over to you, Ann.
Well, thank you so much, Sarah, and thank you for moderating today's terrific panel. So, Edward, if you can bring up the slides, I'll go through the report and then we'll hear from our panelists as they reflect on it. Next slide, please. Before we get into the substance of the report, I really want to call out and thank the authors from PCC and from Morehouse NCPC. First, Larry McNeely, he's policy director at PCC. Megan Douglas from MSM NCPC, that's a little bit of a mouthful. Noah Westfall from PCC, I also contributed to the report. Dr. Ann Gagliotti and Dr. Dominic Mack, who we will hear from today. So pleased to have this kind of collaboration. In terms of reviewers, you've heard from Sarah Combs from the National Partnership for Women and Families. We also had Anders Chin from SGIM, the Society for General Internal Medicine, and Carrie Cochran McLean from the National Rural Health Association as reviewers. You can get our report free of charge on our website, and there's the URL. Next slide. So really what motivated this report was conversations that myself and many members of the PCC team were having with various leaders from organizations that, given what we've all been through with COVID, had reaffirmed and recommitted, and in some cases had begun to address the issues of health equity. And in our travels, we found that some did perhaps not have an appreciation for how primary care can contribute to addressing health inequities. So we decided to write an issue brief, which turned into a report, and turned to our colleagues who are also members at Morehouse to partner with us. They've been focused on these set of issues for decades and have really made so many contributions to addressing inequities. But clearly, we've got a ways to go before we close equity gaps. So how can primary care promote equity? Primary care that is comprehensive, that considers both medical and mental and social supports. In many cases, leveraging community health workers can help promote equity, addressing all aspects of care. Getting patients enrolled in insurance, because obviously for health issues, that's your pathway. Providing culturally, linguistically, and appropriate care, care that doesn't match patient preferences and values is not going to be well received. In our era, also making sure that we help support patients so they can really leverage all services, and many which are now delivered digitally. And then finally, incorporating patient perspective and values from patients across the socioeconomic spectrum and all races and ethnicities, so that the care that we provide actually reflects the diversity of patient populations. Finally, we would hope that patients would partner with researchers to help us evaluate care, to make sure that we really are providing care that is equitable, which is, you know, under the quality rubric, everyone should have access to high quality care. Next slide. And I don't think we can underscore enough that we had inequities in terms of health. COVID exacerbated them. And when you look at these numbers, I hope all of you feel the sort of outrage that we do here at the PCC and amongst our members, that you know, we've really gone in the wrong direction, and we have to take very aggressive strides to close these gaps in care that have emerged. Life expectancy falling for almost 3 years among African Americans. Hispanic life expectancy did fall 3 years, and this is just between 2019 and 2020. Rural Americans also experienced a much higher mortality rate during the pandemic. A study came out today that was in the press that in rural communities, Black and Brown patients experienced even worse. So you layer on rural plus race and ethnicity, and it was a double whammy. And also we saw disparities related to income grow. Next slide. Why does primary care matter in addressing these inequities? The heart of the matter is that in a environment where you trust the person on the other side of the desk to give you information and to direct your care and to provide options, you're going to be much more likely to achieve better outcomes. And trust is built over time and through relationships. We all know this in our personal life. This is also true with respect to getting healthcare services. And I think in the last number of years, vaccines were an object lesson. We heard through many, many surveys that people who were skeptical about the vaccines trusted their primary care clinician and wanted to get their vaccines from their primary care clinician. Also, primary care can connect patients to insurance. All the data, and look over at the chart on the right, demonstrates that those who are connected to primary care have better life expectancy and decreased mortality. And you just look through the preventive screening services, care for those with chronic conditions do much better if they're in a primary care relationship. They are more likely to have their mental health needs addressed. They rate their care higher, and they have better access. So, overall, primary care is absolutely critical to enhancing people's care experience, their actual clinical care, which results in higher life expectancy and decreased mortality. We also know that the relationship of primary care, to high value. So you're more likely to get services that are actually needed and necessary, as opposed to redundant and not medically indicated through primary care. Next slide. Another thing that we have to keep in mind is, well, primary care is part of the answer, and admittedly not the whole answer, but a really important lever. It's not available in all communities. And there are millions of Americans, 86 million Americans who are living in health professional shortage areas, and those are concentrated in rural areas. Black and Asian and particularly Latino populations are also less likely to have that relationship with primary care. In our jargon, that usual source of care. And some American Indian and Alaskan Native, you can see there, are even in worse shape with respect to that ongoing relationship with primary care than others amongst the other populations. Next slide. So, operationally, what can primary care do? We talked about comprehensiveness, the comprehensive set of services. We talked about getting patients enrolled, linguistically and culturally appropriate services and digital tools. Next slide. How do we get from those facets of a practice? What are the policy levers we need to make sure that those that primary care can do the job it can do? Well, here are some of the ideas that were articulated in the report. We have seen that more and more Americans are considered vulnerable in terms of the safety net. And so in order to meet their needs, we really need to both maintain and grow our safety net. That is through FQHCs, federally qualified health centers, but it's also through other kinds of primary care. Currently, about 11% of Americans get their care through FQHCs. And we know that the balance of care is provided outside of FQHCs. Much of that care is provided through independent practices that are able to address those in the safety net. Another really important policy action is to better understand what those disparities are. We can do that by collecting data to understand what differences might exist across these different populations, and also to understand what the social needs are of those populations that we need to address in order to close those equity gaps. I spoke earlier about comprehensive care. That's not very easy to provide under our current fee-for-service model, which doesn't support comprehensive teams providing a comprehensive set of services like integration of behavioral health or a community health worker to connect you to community-based services. Reformed payment models like hybrid payment can get us there, and the PCC is advocating for those under the Behavioral Health Now campaign. We also need to expand telehealth flexibilities and continue the ones that we have, and there's now a bill that is making its way in Congress that would do exactly that. In addition, we can have all of those flexibilities, but if people don't have access to broadband, that's not going to do them any good. So we have to continue to expand broadband access, and the infrastructure bill does that. And then finally, as we move to address inequities in care, we should be monitoring how we're doing. We should be evaluating, and where needed, we should pivot in response to where we're not making progress and redouble our efforts and maybe change our strategies. So you can take those slides down now, and back to you, Sarah, to open it up for conversation amongst our panelists.
Thanks, Anne. Thanks for that helpful background and context. And I couldn't agree more with you about the importance of trust and relationships. So to open the discussion up, I have a few questions for our panelists, and then we'll have a few minutes at the end to take questions from the audience. So please feel free to drop your questions in the question box at any time during this discussion. So can each of you share your brief reflections of the report and how the work that you all are doing at your respective organizations is aligned with or supports the 5 important directions listed in the report that policymakers can pursue to strengthen primary care and engage primary care more fully in the fight against health inequities. So I'll start with Dominic.
Good afternoon, good morning to some, and thank you again. First of all, I'd like to thank the Primary Care Collaborative. This partnership, I mean, is good because we have the same foundational principles that helps us with our mission. The PCC has the expertise, the partnerships, and also the ability to disseminate the message. So this was the right partnership to not only do the research and produce this document, but also to get the message out to the community. The National Center for Primary Care, you know, we have some familiar national names such as Dr. Lou Sullivan, Dr. David Satcher was the first director, and Dr. George Rust, who many of our viewers probably know. We've been deep in big data, health equity research. We've done assessments and scientific studies, and also implementations. You know, along that translational science research line that we all are involved in, but we've always been rooted in primary care, producing evidence of the effectiveness of primary care, but also looking at the gaps. One of our first studies was triangulating on the success of public health research in primary care and the importance of it in any innovation that goes to the community. Medical studies, you need that discovery, you need public health to engage the public and the primary care and the health system, but you need primary care providers to get the innovations out. You think about COVID, the way COVID was produced, the discovery phase, the public health phase, but also the importance of primary care, which Anne talked about, but the importance of primary care, getting those vaccines out, the confidence and the relationship with those patients to make sure that we get them into treatment and services. We studied the gaps in care and how primary care is important. lack of reimbursement and services. We looked at the COVID data across the nation and looked at disparities in reporting on demographic data, which could actually help those disproportionately impacted communities. We've also looked at the digital health gaps, especially in the Southeast when it comes to under-resourced providers, those providers who serve high Medicaid, Medicare populations, and that they access digital tools disparately. It's been happening since we started adopting electronic health record. Who adopted it first? Medicaid providers were falling behind in that adoption. The same has happened with telehealth, and of course, the reimbursement problem also just adds to that. So, looking at studies that benefit the effectiveness of primary care and how it improves primary care, federally qualified health centers who do a lot of the primary care can actually improve the health of communities. But we also develop implementations around education and training. But we have a Southeastern Clinician Research Network, which is a PBRN, practice-based research network that supports federally qualified health centers and others to develop these networks to improve the care, do the discovery phase, but also implement programs that would improve the care of their communities, being able to assess that and develop models that are effective. We now we were fortunate enough to be the recipient to develop the National COVID-19 Resiliency Network, where now we're working with community-based organizations across the U.S., territories, and tribes to develop messaging, but also to link these communities to services, primary care services, and public health services that can really help them to improve. So the report, I'll end with this, the report examines the relationship, as Ann stated, between primary care and health equity, and it identifies those practice-based and policy-based levers that all of the advocates and stakeholders for primary care can use to actually move the health system in this nation toward equity, but also toward a better health system. So it highlights the crucial role of primary care, the primary care system, and how important it is for us to go forward. So thank you, Sarah. I turn it back over.
Thank you, Dominic or Dr. Mack. Now I'll turn it over to Louise.
Hi, thanks for that, Dr. Mack. I want to thank all the, glad to join this distinguished panel, and to thank particularly PCC and Morehouse for putting together this report, because really the conversation about health equity is, in our minds, really the conversation that we need to be having. The Primary Care Development Corporation, as Sarah said before, is a community development financial institution with our mission to catalyze excellence in primary care to achieve health equity. We aggregate low cost and long-term capital and lend it to primary care providers and behavioral health providers, particularly who are interested in integrated care, to improve access, provide technical assistance and capacity building services, to improve processes, outcomes, and support them on their justice, equity, diversity, and inclusion journeys, and to build organizational and financial sustainability and stability of those primary care providers. And then we also work the levers of policy and advocacy. New York State, with our support, strong support, was the last state, the most recent state to pass a bill to establish a primary care commission to make recommendations on improving primary care investment, which we would argue is actually central to achieving health equity. So we're very excited about the report, which highlights the link between primary care and health equity. It's not the only thing that we need to do, I think, as Ann said, to reduce disparities and build health equity. But if we don't really promote and build our primary care infrastructure, we will be driving disparities instead of reducing disparities. So I want to make 3 points today that I think support the findings of the report. The first one is that we believe that primary care is in fact a social determinant of health and is essential to healthy people and communities. Second, that when we describe a model of primary care, it looks a lot like an FQHC. And finally, that if we actually want to be successful in this, we have to resource primary care. and we are doing that insufficiently, I think, as the report points out very clearly. So first, in terms of the first one, primary care, access to primary care is a key social determinant of health. It's recognized by the World Health Organization and by the US Healthy People Initiative framework. It reduces overall healthcare costs, and it's actually the only part of the health system that has been proven to lengthen lives and reduce population health disparities. Second, I just want to talk a little bit about FQHCs. And I think, as Anne pointed out, they actually serve a large number of people in this country. They're not the only model, but they're really the main model, one of the key models in what I would say that is actually addressing directly the issue of equity and reducing disparities. They are a federally supported models of care. For those of you who don't know about it, it was born out of the Mississippi Delta and public housing development in Boston in the 1960s as part of the Office of Economic Opportunity. They were built to provide this concept of community-oriented primary care, which in other words is primary care in the context of the community, which the first FQHCs, and if you read the history of Mound Bayou and in Mississippi, it's really, really important because they not only provided primary care directly, but they also used community epidemiology to figure out what were the main drivers of sickness and death in their community, and then to help figure out what were community-based solutions to address those problems. So with the leadership of Drs. Count, Gibson, and Jack Geiger, among many other people, they embarked on a number of things. First of all, workforce training. We would argue that's right, that's critical today, but they really wanted to build a workforce, doctors, nurses, medical assistants, others, coming up through the community to serve the community. Secondly, they looked at things like there's hunger in this community and there's unemployment. So they actually built farms that could both reduce hunger and drive, boost employment, meaningful employment for people to reduce the wealth gap. They built transportation systems, not only to get people to primary care, but to their places of work. They looked and they said, we need clean water in this community, and they helped people dig wells. Those are all things that we know are sort of what now get called the social determinants of health. This is not a new concept. This is a concept that we know is rooted directly in the movement around federally qualified health centers. And so the modern idea of a community health center today is really a place with integrated care, with care across the life cycle, care coordination, care management, where people go who may not have insurance or may have inadequate insurance, where there's a connection to social services and housing and food and coordination with other levels of care. And many FQHCs have specific designations to serve people who are unhoused, people who live in public housing, people who are migrant workers. And so those are populations of people that are critically important if we want to think about equity, but have very limited access to care. So when we think about this idea that 1 in 11 people in the United States get care from an FQHC, let's look at who's actually getting care. And it really is people who in many cases don't have any other place of care, but these are also robust models. And in short, they're really the kind of model that Barbara Starfield really wanted to just really promote it, and those principles that Anne, you talked about earlier. And they're really the embodiment of what we want to achieve in I think, primary care. I would say that, however, we actually recognize that they're not available to everyone. And so PCDC works really closely with FQHCs and other integrated care providers across the country. We provide financing to build new centers, renovate aging physical plant, acquire technology, build their workforce, improve the care, and become more financially sustainable. And this is one of the ways in which we promote health equity and racial justice. But we also know that there still remain significant disparities, and all of those models have to do a better job. And their maternal mortality crisis among Black women in this country is a great example, and we can talk more about that later. Which brings me to my final point, which is that primary care is frankly under-resourced by any measure. As the report calls out, on average, primary care gets about 5 to 7 cents on the healthcare dollar. But we need resources, and it's not just, sometimes people say to me, well, you just want doctors to get paid more. And I have to say, primary care doctors do get paid a lot less, and that's really proven and very clear if anyone wants to look at the data. But that's not the only issue, right? The salary and wealth gap is real, but we also need to think about how do they adapt, these primary care providers adapt sort of the newer generation of technology, including telehealth. How do they build their workforce? A whole variety of other things, not only that, and physical plant that we really need in order to build the workforce. I want to just say one last thing, which is that the data in New York City is illustrative, and I have no reason to believe that the data is different anyplace else. We did a recent study on the impact of COVID and redlining, two really important things that have driven inequities in this country, on just the primary care provider, just even the quantity of primary care providers. And what we found is 10 more primary care providers in a community per 10,000 people meant 26 fewer preventable hospitalizations for 100,000 people, 35 fewer COVID-19 hospitalizations, 9 fewer COVID-19 deaths, and 5 fewer all-cause mortality deaths. And the lowest income communities in New York City have 4.5 times fewer primary care providers than the highest income neighborhoods. And in the red line areas, which we know were deliberate disinvestment by banks in the 30s and beyond, have only 27 primary care providers per 10,000 people, as opposed to the best neighborhoods from the point of view of investors at 72 primary care providers for 10,000. So we have a long way to go. And I would argue that directly investing in communities, in disinvested communities, by bringing capital and technical assistance and reimbursement and improvement in salaries, including to improve the number of primary care providers in those communities, is actually fundamental to addressing health equity and racial justice, which is kind of what we all want to do. Because if we're not doing that, I don't know what we're doing.
Thank you, Louise. There's a lot to unpack there, and I'm looking forward to teasing some of the things you pointed out in our discussion in a few moments. Last but not least, Dorothy, please give us your brief reflections and from your perspective as a consumer advocate. Dorothy, I think you're on mute.
There we are. Sorry. So I was saying I wanted to thank the group for including me in this, and thank PCC and Morehouse for this excellent report on these important issues. And this is a really important conversation. I work for AARP, which is the largest nonprofit, nonpartisan organization. We have 38 million members that span generations. We are 4 generations, 50 and above are our members. And our agenda is really focused on health security, financial resilience, and social connection. And when I think about how our agenda and what we're active on intersects with this report, of course, we've also supported primary care and continue, and I'll speak to that specifically. But our broader agenda is really getting at those social determinants of health that others have talked about before me. We are very active around housing and transportation and what we call livable communities, because we think that is really important to be the underpinning and is so determinative of how you present to the health system and what your health looks like when you get to the doctors. So that connection and the interrelation there really struck me that we are on the right track with the agenda. One of the things that we're also looking at is disparities. As an organization, we see fighting disparities as core to social mission, to empower people to choose how they live and age, and that's all people. And we see it as everyone benefits when health and income disparities are eliminated. So primary care, we agree, is foundational and critically important to communities, and I think the report does an excellent job of really illustrating its importance in addressing inequities. When we look at the data, and AARP's work spans research, advocacy, programs, education. So we're always looking at the impact on Medicare beneficiaries as a core program for our constituency, and we see the same disparities that you've cited in this report. You know, we see that people of color are less likely to have usual source of care. Many of them who do are using the emergency room and would benefit much better from having a primary care clinician. And there's a whole range of data that we have on that really Black Medicare beneficiaries, for example, are more likely to be hospitalized for exacerbations relating to chronic conditions than white beneficiaries. So when we look at that, it's just one stat that's illustrative of the importance of primary care and that coordination. And that really underpins why we think primary care is so important. The other thing that struck me is just connecting some basic things like health insurance. We're very active on trying to expand Medicaid and supporting the expansion of Medicaid in states where it hasn't expanded as a result of the ACA allowances. And I think, you know, insurance is necessary but not sufficient to get care. And the report talks about that, but we still have a lot of basics to get to, as well as ensuring that when people do get care, it's culturally competent. And we've talked a lot about cultural humility and the need to really continue to have that conversation and to upgrade training and continue to train not only practitioners, but everyone who intersects with a patient to make sure that cultural humility is there and it really does achieve cultural competence in delivering whatever services are provided to the individual. And then I just want to highlight 4 quick things. Workforce issues we're very active on. I don't go anywhere where there isn't a conversation about the challenges of workforce. COVID had a really terrible impact on the workforce. The retention issues are very real, and AARP has long supported. We've been very active in the nursing realm, in particular, trying to get more nurses into the pipeline. There's a real shortage around nurse faculty to expand the seats, and we continue to work on that. And I think workforce issues are really essential and critical to work on an ongoing basis. And the other thing we're very active on is family caregivers, because family caregivers, we don't want people to forget, are really kind of the backbone of the workforce. They're unpaid, but they're in there. So in whatever community it is, we need to connect family caregivers into the support systems, because they really are the people that help individual patients both access care and maintain their health in whatever the treatment protocols are that they need. So we're very active on family caregiving. We have some very good resources around that. The other point I will make is telehealth. We're also very active in advocating. We think telehealth has lots of promise, but we also are very aware that people not only need access to broadband, they need affordable broadband, they need affordable devices that are there, and they often need support and education to be able to use it. And so we acquired an organization called Older Adults Technology Services, and that provides support and education and training to older people on how to use technology and access it. And we need more of that because it's not just getting broadband in place, although again, like insurance, you need the bottom foundation and then you need to keep building forward. So we work on that as well. And finally, I will just say data. You know, data is not a sexy issue, but it's an issue that needs ongoing attention. And our state offices have been getting much more active about getting granular data and really looking at data at the local level, because often things get reported at the state level and you don't really see the underlying disparities in communities that are predominantly people of color in the distribution and access to services. So we feel very strongly about data and the need to collect it, stratify it as granularly as possible, and really pull the insights out. And data is only good if you act on it. So we're also very, very important to draw those insights and act on that. So with that, I will leave it. But again, I will say the report was just a pleasure to read, and I think it really brings in very clear ways how primary care is so essential and foundational to trying to reduce inequity and disparities.
Thank you, Dorothy. So Dominic, I'd like to start with you, given your background as a chief medical officer in your prior life at a community health center. You know, just as Louise mentioned, FQHCs, community health centers, are a critical component of the safety net. In fact, prioritizing the health of those who have been historically and systematically underserved requires building on the strength of community health centers and other safety net providers. So, you know, given your experience, can you share why some may say that strengthening the primary care safety net is the first step towards advancing equity, and what are some important policy levers to support safety net providers?
Yes, thank you. Research has shown, and we've done some of the research, that especially in the rural areas where you have federally qualified health centers, that you get improvement of outcomes, especially around certain chronic diseases such as diabetes. So I'll just say that the research shows that FQHCs can be effective. When you're talking about access to care, federally qualified health centers, that's why they're called safety net. They fill a gap that other health systems are not able to fill for those who are uninsured. You look at the difference in the policies across the state, and those states who did not take Medicaid expansion, such as Georgia, federally qualified health centers played a big part in adding to the infrastructure so that we could support those uninsured patients. So the Federal Qualified Health Center, and also, let me say this, also it provides a great place for primary care providers and also specialists to actually train, to begin their training and to understand underserved communities. So it has multiple roles of importance around improving population health, around building a safety net health system, but also informing, educating, and training providers who will serve the disproportionately impacted communities. There have been a lot of policies put forth that brought a lot of funding to the federally qualified health centers over the past few years, even during the time where a lot of states did not take expansion. So I would say that Congress has been favorable in a sense, not enough, but as favorable and understands the importance of federally qualified health centers and what they can do within community. So I think that I'll start there and address your question. Thank you.
Thank you, Dominic. Louise, so at the very core of your work, as you mentioned at PCDC, it's really indeed, you help expand and strengthen the primary care safety net, particularly now with safety net providers have been hit hard by COVID-19. So what is your perspective on this issue? Can you share a little bit more about what are specific policy recommendations that your organization advocates for?
I think what we all know is that primary care was really left out of the COVID-19 response for a huge number of months at the beginning. And while I actually think it really was the role of public health, and I agreed with what I think Dr. Mack, you said earlier about the importance of the relationship between public health and primary care. I think that's actually a critically important relationship. I think that really primary care providers were, because they were the trusted people in the community, that they really needed the guidance. I mean, we worked with primary care providers here, and they would call us and they'd say, I'm trying to get masks, or protective equipment for my staff. And when I call these places, they laugh at me because they say that I'm competing with countries and with, huge counties for materials. Like, they don't want to send me 2 boxes of something. Like, they can't do that. So sort of thinking about how primary care and public health work together, I think is actually really important. Once things shifted, I think, in COVID, where it became clear that after the first bolus of vaccinations, which I think really needed to be done in a mass vaccination way, we really needed to get out quickly the vast number of vaccinations that we needed to do. Now the locus has really shifted, I think, to the primary care system to do the vast majority of vaccination. And I think we can see, and it was certainly true in the surveys that were done by the Robert Graham Center and others, that primary care providers were really doing a lot of work, particularly around working with communities who may not have wanted originally to get vaccinated, but they were really the ones who were providing, I think, that kind of guidance. And what this tells me is that we have to figure out a better way of dealing with these kinds of emergency situations. Really a pandemic that was an emergency for a while and then sort of has segued into kind of how we're living our lives, right? That is something that I think we need to ensure that primary care providers are provided the information, that they're included in the resources that are needed. Now, what was interesting is that primary care FQHC has got a lot of COVID-related dollars. At some point, they were really flush with liquidity, and that helped them with the very specific thing of getting out a lot of vaccinations very quickly. But I also want to point out that independent providers in particular are actually a really important part of the primary care ecosystem, and they were left completely out of the COVID response. And I think in general, a lot of those independent providers, particularly in, say, an urban community like New York City, they actually serve a lot of low-income communities, particularly like language groups or folks that live particularly close together and have sort of a cultural connection to those primary care providers. That's really another place where there need to be trusted providers. But I would say that when we actually looked at the disparity between where people were getting COVID and dying from COVID at the beginning, the resources were not following them. The resources were going to sort of major academic medical centers, not to community hospitals, that kind of thing. And I think that is sort of, I always, just like everything else in life, like, let's follow the money and see where it goes. So I think that was one of the big lessons of COVID, is it just did not reach deeply enough into the primary care community.
To build on Louise's comments, because we were certainly in the mix of those conversations and in meetings with the White House, trying to urge them to more rapidly involve primary care in the distribution of vaccines. And for lots of reasons, some of them, with the Pfizer vaccine, well-founded, the cold storage requirements. But as things evolved, I think we needed to do a better job getting primary care in the game. And I think that the delays have helped to, unfortunately, contribute to some of the vaccine skepticism that we have. People had questions and they wanted to talk to someone they trusted to get answers, and they didn't have access. They might have had a conversation, but then there was no ability to follow that right there in the office with a vaccine. And so that's really unfortunate. We've got to do work to not only invest in primary care, but also invest in public health and the infrastructure that allows those two sectors to share data, to communicate, and to really manage these pandemic kinds of situations. But it's not just the pandemics, it's in general, these public health issues that we face. If we have those kinds of coordinated and interactive efforts, we're going to do better in producing health. So I think that's a point really well taken, Louise. Clearly, there's lots we can be doing to address inequities. It involves primary care. It also involves public health.
Thank you all. So I'm going to switch gears a bit and talk about an important point that Dorothy made in your opening remarks about data collection. So, at the National Partnership for Women and Families, we have been strong advocates for the need to focus on improving data collection and analysis across all healthcare stakeholders, so we can, identify inequities, target policies to improve them, and track progress. With proper support, primary care practices can play a critical role in the appropriate collection of self-reported social needs and demographic data. So Dorothy, I know that AARP collects a lot of information of its own members via survey research, its demographic analysis to identify your own priorities and policy recommendations. What are some of AARP's best practices? And also from the individual and caregiver perspective, what have been some of your policy recommendations or concern on the issue of data collection, reporting, and analysis?
Yeah, I think data presents such a great promise. I mean, on the upside, we learned so much from it. And the example I gave, in one of our state offices, they collected data from the state around the distribution of home and community-based care, and really revealed a disparity that was there. Even though the state had a fair amount of home and community-based slots, they were all going to certain counties, and the distribution wasn't as equal as it should be. And that really provoked action immediately. But we also work really hard to talk about data protection and privacy issues, because you need to meet people where they are, and there are concerns about that. And so we collect data, but we're very careful about anonymizing it. I'm going to use that word carefully. And we believe that data has a whole range of possibility and importance in research, but we need to create that balance of ensuring the privacy and protection of it. So privacy and security, the two dimensions that are there. And the other piece that we really want the system to think about, and we talk about this a lot, is the burden that data collection can place on individuals. So even as an individual consumer, you often see these surveys coming from everyone. Can you respond to this? Can you tell me what this product was like? And so we really need that coordination among providers so that data is collected once. There isn't a repetition of data asks and those things. So one of the things we talk a lot about is trying to ensure that from the consumer perspective, we want the data there. It's important. Consumers need to understand, and I think you need to meet them where they are to explain. It should be very transparent. What are we doing with your data? Why are we collecting it? Are we selling it to then have advertising to you? That's, if it has these broader goals, those need to be clear and transparent. And I think consumers do support it when they hear that, but they need a clear and transparent way to do it. And we try to have our own privacy practices very simplified, very transparent. Anything we're collecting, we're very clear about what we do with it and the limits of what we do with it. And if you want to opt out, you have that option. So I think there are balances to be struck here in terms of meeting people where they are, supporting them to collect that data, and then really the other piece that I feel strongly about, and we've worked really hard, is often we're data rich and insight poor. We have so much data. Are we looking at it? Are we using it? And so we've really tried to be a voice of make sure you're transparent about what you're collecting, you know what you're going to use it for, you're clear with the consumer what you're going to use it for, you have good privacy and security protections, and then really there are lots of possibilities, but there's a complexity to doing it.
Thank you. So I'd like to turn over.
Could I just say there's also a point of view of the primary care provider, which is like we can ask them to collect more and more data, but at some point that is also kind of an issue for primary care providers who, and I think I totally agree with Dorothy when you say we need to be better at aggregating data, analyzing it, and making it actionable in real time. And that's the thing that I think we lack on, even if we do collect data. So I would just argue that for the purposes of equity, if we notice their X community has, this particular community has high amounts of diabetes or, hypertension or preventable hospitalizations from hypertension, whatever it happens to be, like the value you're going to get at looking at every individual provider's data versus just saying like, as a group, you providers ought to be doing this, and then letting those organizations review their own data to make sure that they're doing the right thing. But I think sometimes we worry a little bit too much about like getting it from every single primary care provider. There's a lot that you could do with public health surveys at the community level to inform action. So I think we have to be more thoughtful about what kind of data we need to collect from whom and when. And that I think, which doesn't say we don't need data, but then we need to have the primary care providers certainly feel like it's actionable data that they can do something with to support their, looking at disparities and addressing them in their own ways.
Absolutely. Thank you for your input and feedback. So just switching gears to telehealth, I know we only have a few minutes, and we all know that telehealth utilization in primary care has skyrocketed during the pandemic and has significantly changed the delivery of primary care in the present, and also raises questions for the future. So Dominic, I wanted to ask you, like, what's unknown is whether the federal government will continue to embrace the flexibility realized during the pandemic in the years to come. And as we begin to emerge from this pandemic, hopefully soon one day, and start to think about entrenching policies and practices that that were developed in crisis and how we use telehealth policy as an opportunity to intentionally build a primary care system to meet the needs of those communities most impacted by systemic inequities. How do we do so in a way that is designed with
Hey, your last few words cut out, Sarah. You say, how did we do so that?
Sure. How do we use telehealth policy as an opportunity to intentionally build a primary care system to meet the needs of those communities most impacted by systemic inequities?
Okay, yes. Yeah, we've done studies across the Southeast to look at um, the telehealth, mostly around mental health was reimbursed, but around other illnesses, there was low reimbursement. We were looking across Medicaid providers. So that's a problem in general, but especially with those in the disproportionately impacted community. Bottom line, I don't know, it's really difficult for me to understand what's so difficult about reimbursing for tools and services that have been shown to be effective. We get one code put out by CMS that's covered, but when it requires, other, many codes just for the providers to get paid. So simply, I mean, we really have to look at these case studies that we've done to show the effectiveness of telehealth and other digital health tools. And we have to vote to pay for it. I think professional organizations are basically supporting, but we're politicizing too many things. And the underserved communities are the ones who suffer the most because other communities can pay for it if it's not covered for by their insurance. But telehealth is not the end all to be all. Certain situations, it's not effective. But in those cases where it's effective, beyond the face-to-face, I just simply think the cases are proven. So we just have to continue to advocate for reimbursement from CMS and other funders.
Thank you. Do any others want to add any comments? All right, so I think we have time for maybe one more question. To the point about primary care, primary care providers were able to transform their care delivery virtually overnight during this pandemic. Some payment models weren't as easy to adjust during the crisis for others. I think we can all agree, but please push back if you feel differently, that the underlying primary care payment structure must be transformed and designed intentionally with equity in mind in order to truly leverage primary care to advance health equity. So Louise, what are some key primary care payment and investment policies that need to be implemented in order to realize primary care's full potential?
So I'm just gonna say one thing. I actually have to say I'm a little agnostic as to which perfect model there needs to be for payment. But I would say this, if you want to address disparities, health equity, racial justice, you actually have to invest more in disinvested communities, not just equally to other communities. And we have not done that, and none of these payment models do that. And that's, I think, a fundamental flaw in how, in sort of the payment conversation that we're having today.
Well,
yeah,
I mean, I completely agree about investing more and for safety net practices who don't already have the data and infrastructure to be able to, manage on a population health basis. That's going to take even more investment, right? Than maybe your more middle of the road practice. But I also think, and we have evidence to demonstrate that it is the prospective payment model that actually allows practitioners to get off of the fee-for-service chassis and build out a team that can provide this comprehensive set of services that can help us address the inequities. So that's what we're promoting. The FQHCs have a much richer payment model, but it's hard to imagine that we're going to be able to do that across the entire system. So I think moving to value-based and upstream can help us shift resources where they need to go.
I think that's completely right. And I do think that it's about prospective payment. And the way that we pay people is like, well, we're going to give you, 50 cents on the dollar, and then maybe if you prove all these things, we'll pay you. But that's not a business proposition. That's not how organizations work. That's not how any business works. And if you actually said that that's how you're going to fund a restaurant or, an apartment building, people would laugh at you, right? The healthcare system is just not designed in a way that really functions towards a prospective payment, or rent every month in order to make sure that you have a place to live, that kind of thing. So I agree with you on that. That's truly, and I wasn't trying to be flippant, but I was really just trying to say we have to get out of this mindset that we're going to pay pennies on the dollar for primary care, and particularly primary care in communities that are have the worst outcomes, because that's how we've designed it. It's not accidental. It's changing the intentional way that we work in disinvested communities and saying they actually need more. So they need more primary care providers than maybe a wealthy wider community. They need more resources, and that's where we should be aiming. We shouldn't just be aiming for equal. That's not equity. That's less than equity.
No argument there.
Agree. Well, we are actually over time, and I just want to thank our great speakers and Anne and the audience for being part of this really dynamic and lively discussion. I hope all of you enjoyed it as much as I did. I hope you all learned as much as I did. And as a reminder, the recording and slides will be posted within the next 24 hours. Thank you and have a great day.